Today, see an intricate surgery that could restore function in a patient's arm after a severe injury to nerves in the neck.
You have huge response from the forearm.
Then, discover how 3D printing is changing the way surgeons prepare for complex operations. And a vaccine to prevent breast cancer?
How wonderful it would be if we could ultimately tell somebody that by just receiving this vaccine, a breast cancer diagnosis is not something that they would have to face.
Researchers say it's possible, and they're testing a first-of-its-kind vaccine to ward off one of the most common kinds of breast cancer. That's all coming up on this episode of UPMC Physician Journal, and it starts right now. UPMC is among just a handful of centers in the country and the only one in the region to offer a highly complex operation on patients with severe injuries to the brachial plexus. In today's first story, meet the team and see the surgery to restore one young man's ability to use his arm and hand.
I was always a big adrenaline guy. I've loved motorcycles since probably 16. You feel like free and like the wind feels nice.
22-year-old Elijah Kaleda is a senior at Penn State University. He plans to work as an industrial engineer in the future. But one night in October of 2023, Elijah's future plans were suddenly put on hold. That's when the motorcycle he was riding collided with a tractor-trailer truck.
So I tried like swerving to get past him. There was a car hanging off the trailer. I hit the car that was hanging off the trailer. And then my friend said my bike just kept going straight. And then I was just laying on the ground a little bit further ahead, just unresponsive.
Elijah was airlifted to the hospital where he regained consciousness 24 hours later.
When I first got an injury, I could move my fingers just a little bit. I couldn't really move my arm. That was weird.
The symptoms persisted and were eventually attributed to a severe injury to the brachial plexus. It's an intricate network of nerves that send signals from the spinal cord in the neck to the upper extremities.
Your nerves are like electricity cables. They conduct a signal, either from your brain to your muscles to move, or from your skin to your brain to feel. There's a lot of crossing between the cables, so it gets pretty complex pretty quickly. If you have one problem up there, it translates into a lot of problems all the way down into your hand.
An injury to the brachial plexus can stretch or compress the nerves. Minor injuries may heal on their own, but when they're severe, damage and scarring could lead to paralysis, weakness, loss of sensation, or intense pain. If surgery is likely to help, it must be done within 6 months of the injury.
And so you're on the clock.
Without a healthy nerve to stimulate the muscle, it will continue to atrophy over time, and then the damage becomes irreversible. In this extremely complex surgery, teams work simultaneously. The procedure takes upwards of 12 hours. To start, one team exposed the damaged region and identified a suitable nerve root for grafting.
And what I found during the surgery is that the nerves were completely pulled apart because you can't see that from the outside. It was not going to heal on its own, and so he was not going to be able to move his shoulder or bend his elbow if we just waited.
Another team prepared the patient's right leg to harvest the sural nerve, an expendable sensory nerve that will replace the injured one and serve as a pathway for nerve regeneration.
Or 15 safe? You want 10 safe? You want 10 or 15? 10.
UPMC is one of just a few distinguished centers in the United States to specialize in brachial plexus reconstructive surgery. It averages about one of these procedures each month.
It's a very hard and complex surgery, so you want people who do that more often, right? Because it's that network of nerves.
You have huge response from the forearm.
Great.
In addition to it being a complex network, there's the two big blood vessels, and so the nerves kind of wind around that. And so it's a lot happening in a very small surface area. Where the injury sits can vary, and so what's the right plan for that person? That's complicated. And this injury is pretty rare. And so it makes sense that you want someone who specializes in that, dealing with that specific area.
And so this is the nerve from the leg, the sural nerve graft, and all of this was torn. And so we attached that nerve graft here at the C5 nerve root, and then where it normally attaches down here, we also repaired it.
The next step is a free muscle transfer to restore upper extremity function. So another team harvested the gracilis muscle from Elijah's right thigh. To supply it with energy, the muscle will be connected to an uninjured nerve that's close by, along with 2 blood vessels.
Here, you can see the blood vessels. They were going to put the muscle from the leg. It's going to get blood flow from here. It's going to be able to allow him to bend his elbow.
The ultimate goal is to restore the bridge between Elijah's brain and the messages it sends to his shoulder, arm, and hand. But the surgery's full results are not immediately apparent.
The blood vessels you know right away, because if there's no blood flow, the flap doesn't look good, and you can see it in the OR, and so that's pretty gratifying right then and there. But the nerves, you don't know for a while, and so that's the hard part. So for example, for Elijah, he had a lot of surgery, and we're not going to know until 6 months, maybe a year, before we get any signal, before he feels that that muscle starts working. And so that's sometimes a little bit frustrating. You got to know beforehand that that's the time it takes. And in a way, it's almost, okay, you make this investment now so that hopefully in 6 months to a year, it pays off for you. And so you really got to take that long-term approach. I try to time it really well and then give it everything we have.
I'm basically just focusing on like my PT, but it is rough just waiting to see what actually comes back, like not knowing just yet. Basically, I do want my bicep and tricep, stuff like that to come back, so I'll be able to type at least, like typing, for a job and stuff. I do plan to get back on a motorcycle in the future.
Thanks, everyone.
Thank you.
I really love surgery. There's no doubt about it. Otherwise, I couldn't do this. And so doing a very complex surgery, thinking it through beforehand, executing it, and I see people who are happy and I made them better, there's nothing better than that. That is ultimate gratification. Those are the things that make a good day.
In the world of biomedical engineering, experts call 3D printing an undeniable game changer. Right now, meet key players in UPMC's 3D printing program and see how the team uses 3D printed models before and during surgery to advance patient-centered care.
I think it would drop down the anterior for it.
You want to go straight up and down? Or?
Yep, that's perfect. So if you pull the tooth that you want to go through, and then you just cut right there, that's a very easy cut.
This is a 3D printed model. It's an exact replica of the jaw of a patient, and she's scheduled to undergo surgery in just a few days.
This edge has to be flat.
3D printing technology has been embraced by medical teams because it allows them to simulate a surgery virtually before actually performing the surgery physically.
With 3D printing, I can take the imaging that a patient has undergone and put it in the hands of the surgeon to sit down and really help tackle how to best take care of a patient. Or put it in the hands of the patient who's going to undergo the procedure. And seeing the light bulb go off in a patient's eyes when you show them a model of their tumor and how you plan on treating that tumor. If they say a picture is worth 1,000 words, then a model is priceless.
These customized anatomic models are created from the patient's two-dimensional CT scans.
Emilia has something called an amyloblastoma. And so this is like a benign tumor of the mandible that will continue to grow. And so what that means, it can erode the bone and it can cause your teeth not to line up and it can be disfiguring.
The surgical team will remove the tumor and affected portion of the mandible and then replace it with plates and a portion of the patient's leg bone.
And now it's put a piece of fibula there.
Where to cut, where to drill, how to pre-bend the plates. All of those decisions can be precisely determined ahead of time, thanks to the 3D printed models.
Perfect. We're ready to go.
All right.
In our planning session today, we discovered a lot of things that without 3D printing, they might have not understood until the case had actually started.
3D printing is a game changer for us. Now we can sit in a room a week in advance, everybody's relaxed, and we can really understand three-dimensionally where the tumor or the lesion is. We're able to plan all of our cuts and how we're going to remove the tumor. And then we can plan the reconstruction in the exact same fashion.
I thought we should meet one more time just to go over the plan again and make sure that you're comfortable with everything.
I love it for a number of reasons. Number one, patients talking to someone. So in Emilia's case, I can sit down with her and say, okay, here's where this tumor is of the jaw. Here's how we think about removing it. And here's how we rebuild you. You know, your tumor is a little farther behind this area. And so we have to reconstruct a little bit farther back. Patients are nervous. Emilia's nervous. And so this is one way I can reassure Emilia that we can rebuild her jaw in a way that she'll have a normal life after this.
Yeah, it came off of the M. This is the part of the bone that we're getting rid of.
Yes.
Before, CT let you see inside of people. You got to see things you could never see before. Now you can handle things you can never handle before. Literally anything that you can capture with imaging and beyond. CTs are required in slices. So we'll go slice by slice in a semi-automated way to basically color in the anatomy that we are interested in. We'll do that through the length of the CT, and then that becomes the area for our digital files, and we turn it into an outline, and then that's what we later print. The materials that we use to print these are photopolymer resins. It's basically a liquid plastic that cures when exposed to UV light. They are printed in sub-millimeter precision, so each layer that goes down into the model is 0.1 millimeters, so our finest resolution is about 0.2 millimeters.
UPMC's 3D printing program creates models and surgical guides for just about every specialty within the hospital system, producing hundreds of models each year. That makes it one of the busiest point-of-care 3D programs in the country.
We're going to take really good care of it. It's going to be okay. And so the goals of the surgery, at least from the first part of it, is to remove all the tumor and make sure it never comes back. And that's always the first goal of these types of surgeries. And then the second goal of the surgery is to rebuild Emilia in a way that she is happy and able to do everything she wants.
I would love to get dentures, implants, something so I can chew on that side and kind of have my face more back to normal because it is so bulbous on that side.
I think Emilia and other patients really don't know how many people are behind the 3D printing technology, the radiology group, the engineering group that really helps with this.
And I know that there are always a lot of nurses, anesthesiologists, stuff like that, but I would never expect the biomedical engineers or really how many people there are. It gives me a lot of peace of mind knowing that they know exactly what they're going into. Not only are they seasoned in this specific kind of tumor, but they've literally done it on me without doing it on me beforehand.
It's more relaxing in the operating room. We've already pre-planned everything. Everything's ready for us. We have all of our models and kind of feel everything in our hand as we're going along. And then, while we're there, Elliott's in the room a lot of times and saying, okay, well, here's the guide I built for the fibula cut, or here's the guide I built for the mandible cut. The time saving is another tremendous aspect of this.
So there's a tumor there.
Yeah.
So I figured it was going to go through that nerve and through this tooth. And the cut angle's there, see that?
This surgery used to take up to 15 hours. Precision planning ahead of time using 3D printed models has significantly reduced that.
And now this could be 4 to 6 hours and people are up sitting in a chair in the afternoon and able to talk to their family the same day of surgery.
Nice work, intact. Good margins there. Good margins. Here's this. Here's tumor.
Oh, that's a little ball.
Look at that. It's pretty amazing.
That means the patient spends less time under anesthesia, reducing the potential for complications. Using models to prepare before surgery and custom surgical guides during it, the team was able to remove the patient's tumor and reconstruct her jaw.
Okay, we're almost there.
3D printing really has become a core part of how we take care of patients and specifically plan out, I'm going to cut in this area and in that area, and then help to create the tools that allow us to replicate that plan. Never gets old.
I know what Emilia needs to help design the best jaw reconstruction for her and give her the best long-term outcome. I can provide all those things for her with this technology.
After decades of research and vaccine development, UPMC and researchers from the University of Pittsburgh have launched a clinical trial to test a vaccine to prevent breast cancer. And our final story today, join a patient inside the clinic as she becomes the very first person to receive the vaccine. This may look like just another clinic visit, but the moment marks a new chapter in Pittsburgh's storied history of vaccine development. This is the first patient to receive a vaccine that may prevent the most common type of non-invasive breast cancer.
The study is of a MUC1 vaccine in women newly diagnosed with ductal carcinoma in situ.
Dr. Olivera Finn studies how cancer cells and the immune system interact, and she has long believed the immune system can be primed to fight cancer.
Cancer grows over a very long period of time, and during that time, it is actually playing with the immune system, meaning the immune system destroys some of it, it grows, it destroys it again, and then when we are diagnosed with cancer, it is because the immune system finally allowed it to escape. Once it was very clear that there was this powerful immune surveillance of cancer, and we learned how it works, then we can boost it.
Back in 1989, Dr. Finn was the first researcher to identify MUC1 as a target for human immune response. It's a protein that covers the surface of all epithelial cells. In tumors, MUC1 is expressed in an abnormal way. The vaccine trains the immune system to recognize that MUC1 abnormality and provoke an intensified immune response. It's been a demanding journey for Dr. Finn and her team, but they've finally arrived at this historic moment: the MUC1 vaccine's trial in cancer prevention.
People think there's this eureka moment, but the truth is that it's a lot of incremental discoveries that finally all come together. And that's a good day at work.
Women admitted to the trial have newly diagnosed ductal carcinoma in situ. All will receive the standard care, including surgery, but some of the participants will also receive the MUC1 vaccine prior to surgery.
We're going to vaccinate them at the entrance to the study 2 weeks later, 10 weeks later. At 12 weeks, we evaluate the immune response, and then they go on to standard therapy. Women who are diagnosed are often treated with surgery, sometimes additional radiation, chemotherapy, depending on what pathology says. What we are hoping to do is to vaccinate women who are diagnosed with DCIS and use that as the only treatment for those women, expecting to generate an immune response that would go to the site of that lesion that they see on the mammogram and eliminate it.
And we know that these women are at high risk of developing breast cancer in the future, and we're trying to see if this vaccine can prevent that. The same way that your flu vaccine every season activates your immune system, it destroys that flu virus before it can really grow and cause problems. Ultimately, what we want to do is train a patient's immune system to recognize the cancer when it's microscopic before it has a chance to develop into an actual tumor.
The reason why this is groundbreaking is because we are trying to address the problem of cancer in a different manner. When we talk about cancer treatment, what we are doing is giving someone therapy in order to stop a disease. When we talk about prevention instead, the hope is that we can prevent a problem from becoming a threat to your health and a threat ultimately to your life.
Ideally, the study also will shed light on whether the boosted immune response would continue to recognize abnormal MUC1 cells and control any lesions that may come back.
We're seeing a full-blown tumor, but in the vaccination setting, hopefully anti-tumor cells come in and go after and kill any tumor cells that are present. You see more immunity.
Long term, the hope is that the vaccine could be given to people who are at high risk at a young age to prevent cancer from developing at all.
How wonderful it would be if we could ultimately tell somebody that by just receiving this vaccine, a breast cancer diagnosis is not something that they would have to face.
The implications are enormous, and not just for preventing breast cancer.
In case of MUC1, you can apply them to over 80% of all human tumors because they all express this form of MUC1. We are testing it now in one premalignant state at a time. But if we get all these good results, then it'll be for all of them.
We are looking for 50 patients to participate in the trial.
Those of us involved in this clinical trial are hoping for something better with this vaccine. Our patient, Maria Kitai, is also hoping for something better. That's why she decided to enroll in our clinical trial. We are so grateful to you, Maria, our pioneer.
I was diagnosed after I had a mammogram. I was really impacted by the courage that my cousin Clara showed, and she had breast cancer. She said, it's so painful to have this.
I always look at what can we do to make it better for the patients, to make it easier for them. So when I'm able to put a patient on a really interesting research study to benefit them or benefit the next generation of patients, that is why I do my job.
I was speaking with my sister Anita today about the idea that my dad always said, to go the high road. And we need to put ourselves out there and participate in these studies and take the high road to help others. And that's what this is all about.
All our participants in all our trials so far have always said, I want to do everything so that my daughter, my sister, my brother, nobody else has to go through what I've gone through. So with these preventative trials, I anticipate that people will join them for the same reason, that nobody else goes through the agony of cancer diagnosis.